This is Radio Health Journal. I'm Reed Pence. This week, knee replacements. Patients can be miserable when they don't work. But how often is that?
It's actually a highly effective procedure for 80% of people. And I think that's sort of the glass half full side of the story.
The pros and cons of getting a new knee when Radio Health Journal returns.
I'm Nancy Benson, host of Radio Health Journal. If you enjoy listening to Radio Health Journal, you'll also like our sister show, Viewpoints, which covers a wide array of topics from education to history to the environment. Here's a preview of what they're covering this week on Viewpoints.
The only snowplows were people driving around in pickup trucks with wide tires. That was about it.
Understanding the winter storm in Texas last month and what went wrong. Then,
this constant checking is the real villain if we want to look at productivity, especially in the early 21st century, is because to check this inbox all the time requires you to shift your context.
How many times a day do you pull away from what you're doing to check your email? I'm Marty Peterson.
And I'm Gary Price. These stories in depth this week on your public affairs magazine, Viewpoints.
Listen to Viewpoints on your favorite radio station and subscribe and listen to shows anytime on Apple Podcasts and Google Play.
Millions of people in the United States are hobbled by arthritic knees, and increasingly they're looking to knee replacement surgery to fix it. In a normal year, more than 700,000 Americans have a knee joint resurfaced with cobalt, chromium, titanium, and plastic. That's more than double the count from 20 years ago, and there are plenty of reasons, according to Dr. Dan Riddle, professor of physical therapy, orthopedic surgery, and rheumatology at Virginia Commonwealth University.
Some of the driving factors relate to the fact that the population generally is getting older. Some of the driving factors relate to the fact that obesity is on the rise, and obesity certainly is highly associated with the development of knee osteoarthritis, highly associated with being inactive, and all these factors play into a high prevalence of osteoarthritis of the knee, much more so than decades ago.
Patients' expectations for the quality of life they have as they get older certainly have changed even in my lifetime of practicing medicine. So a person who may have felt they didn't really want the replacement as they got older, they were doing fine, may very well now feel that they would like to have the replacement, that they want a better quality of life.
That's Dr. James Rickert, president of the Society for Patient-Centered Orthopedics.
Also, and equally important, is as the technology has improved, we do them on younger people. And so there is this bolus of baby boomers coming through who have been active in their lives. There is arthritis in their knees, and we can address that with a replacement. And we can do that in younger people with the expectation that the replacement will last a long time.
However, the success rate for knee replacement is not 100%. Up to a third of people who've gotten a knee replacement still have some chronic pain, and a study in the journal BMJ finds that about 1 in 5 patients are unhappy with their results. Some people are surprised the numbers are that high, but Riddle says they're actually pretty good.
It's actually a highly effective procedure for 80% of people. And I think that's sort of the glass half full side of the story. That's an estimate that's actually pretty high compared to a lot of other treatments that are done, and surgery or otherwise. That an 80% success rate is actually quite substantial. And when we talk about an 80% success rate, we're talking about, on average, patients who have very substantial pain reductions, very substantial improvements in self-reported function. So the success is true success.
But Rickert says it's important for patients to realize that there are times when it doesn't go right, and that it takes some work to lessen those chances. Still, many of those who expected better can be bitterly disappointed.
The biggest reason patients are dissatisfied with the procedure is continued pain or unmet expectations. So if a patient's not properly selected and, equally important, has an appropriate conversation as they're planning to have the replacement, as they're failing conservative care, for instance, so the procedure is performed, then they're going to be dissatisfied.
The key is figuring out who's likely to fail before the procedure is even attempted. Riddle says doctors have gotten a lot better at that.
We can predict, not with 100% certainty, but predict with a fairly substantial degree of success who's at risk for not doing very well in either pain or function realms. Some people seek knee replacement when perhaps it's too early and they're not necessarily good candidates. And the way we can identify those people is those are people who have very mild osteoarthritis. Those are people who have, on the spectrum of pain with activity, very reasonably low levels of pain with activity or very high functioning. And these are people who, if they have a knee replacement, even if it's a successful surgery on the face of it, may only have very mild pain relief or very mild improvements in activity. And one may question whether all the risk and all the cost associated with knee replacement is worth a few points improvement on a pain scale.
All of that suggests that patient selection is extremely important if we hope to improve outcomes in knee replacements. Riddle's study of hundreds of knee recipients shows that only 44% met criteria for an appropriate recipient. 22% were inconclusive, and about 34% received a new knee inappropriately. So how do we select patients better? First, Riddle says, we need more thorough psychological screening.
I think that's an area where we can improve. The usage of very brief but validated instruments, for example, identify people in a screening format who have very high levels of depression or very high levels of anxiety disorder, aren't routinely used in clinical practice. And the more standard use of these kinds of instruments, I think, could potentially help to reduce that 20% sum if they were used more frequently and if the surgeon then referred the patient to a psychologist or their family doctor for treatment of a mental health disorder if one is present.
Secondly, Rickert says, surgeons need to be a little less ready to do knee replacements on younger patients whose x-rays don't show truly severe disease.
I would try to dissuade people younger than 50 personally. A good replacement, you can tell somebody will last about 20 years. Now, equally important, younger people typically are more active, and there is a life cycle to these things, and if you're much more active than average, the average user, it is going to wear out quicker. So if you look at both the increased activity of younger people and the fact that they do have longer, they have to live with it, so there's greater risk of revision when they get older, it is better in younger people to put it off, live with conservative management. There's no hard and fast rule, but my personal preference is anybody less than 50, I really do try to work with them with conservative treatment.
In reality, all patients who might be candidates for knee replacement should go through more conservative treatment first. Often, insurance requires it before a replacement. And for patients who might be likely to fail with surgery, those therapies may eliminate the need for a replacement for years.
All patients go through some form of conservative care, whether it be pharmacologic, whether it be physical therapy, whether it be weight loss, whether it be intervention with a pain psychologist or clinical psychologist to help with psychological distress that may impede progress. So these are all options to try. We do know that weight loss, particularly when it's on the order of 5 to 10% of body weight or more, can have a substantial benefit and improvement in knee pain, and certainly just generally increasing activity. A lot of patients who have moderate to severe knee pain, particularly on a chronic way, are very inactive. And so activity in and of itself can be therapeutic for these patients, and this can involve visits with a physical therapist to begin an exercise program, to begin a general activity, aerobic activity program, to try to enhance their physical fitness, which can have secondary benefits not only in pain control, but also mental health.
There's many things that can stave off a replacement for a while. The first is getting back in shape, losing those extra pounds. For every pound you lose, you take 7 pounds off of your knee as it functions. So there's many things to do as in terms of medications, injections, exercises, physical therapy, braces, and those sort of things. And when those things fail, no matter what age you are, then you're a knee replacement candidate. And I've done patients as young as 16, as old as 103.
That's Dr. Richard Berger, assistant professor of orthopedics at Rush University Medical Center. He says that one more way to be assured of a good result is to find a surgeon who's well practiced at the procedure.
More than half of the knee replacements done in the United States are done by surgeons that do less than 50 a year. That's less than 1 a week. It's hard to get good at doing anything you're doing only 1 hour a week. I do about 1,000 knee replacements a year. I've been doing that for a couple decades now.
Surgeons who do a high volume of knee replacement have better outcomes than surgeons who do knee replacements rarely. And this probably most frequently applies to patients living in rural areas where the general orthopedic surgeon may do a knee arthroplasty once every 2 weeks or once a month. And those are the patients that generally tend to be at risk for poor outcomes simply because the surgeon doesn't have as much practice at doing the procedure, isn't as efficient at doing the procedure, isn't doing the procedure in a hospital that does a high volume of arthroplasty and is very good at the hospitalization care for these kinds of patients. That's one area that I would encourage patients to seek out high-volume surgeons doing surgeries in high-volume arthroplasty hospitals over the rural hospital where the patient or where the surgeon rarely does arthroplasty or the hospital rarely sees patients with this procedure.
The discomfort and lengthy recovery of a knee replacement, even a successful one, are factors that scare away some patients. Berger says some patients who could get tremendous relief never go through with surgery because they can't spare the recovery time off the job. But now a growing proportion of knee replacements are done in a less invasive way. Berger says it's much easier on the body.
It is so much easier. In fact, it is so easy that we now do outpatient knee replacement. That is, patients come in, have their surgery, and go home within a couple of hours.
Berger says it's not an easy procedure technically. Tendons and ligaments are in the way if you're trying to reach the deep recesses of the knee. Up to now, there's been only one way around that.
If you do it by cutting the muscles, ligaments, and tendons, you have a long, slow, unfortunately painful recovery. That actually doesn't fully recover because those muscles, ligaments, and tendons heal with scar tissue, and it never quite functions the same. So you're talking about a 3 to 6 month recovery, and even that doesn't get you all the way back. If you do it this new way, the recovery is remarkably quick. My patients get back 90% of their full function in 4 or 5 weeks. They're back to their job and back driving in about a week. They're back playing golf in 2 weeks. Doubles tennis in 4 weeks, and singles tennis in 6 weeks. So they have a very quick recovery. They do very little physical therapy because we haven't damaged much to put the knee in. So not only is it easier and quicker, but they get a much better long-term function of their knee, much more back to normal the knee that they had when they were younger.
Either procedure, Berger says, is worth having for the qualified recipient with the right surgeon. You can find out more about all of our guests through links on our website, radiohealthjournal.org. I'm Reed Pence.
2 nationwide surveys find that discrimination is a significant barrier to care for people with Alzheimer's and dementia. Half or more of non-white Alzheimer's caregivers report they face discrimination in navigating health care for their recipient. Dr. Carl V. Hill is Chief Diversity, Equity, and Inclusion Officer of the Alzheimer's Association.
The data suggests we have a long way to go to address lack of health equity in healthcare. More than 80% of non-white racial and ethnic groups say it's important for Alzheimer's care providers to understand their backgrounds and experiences. But fewer than half of Blacks and only about 60% of Hispanics and Asian Americans feel confident about their access to culturally competent providers.
The surveys also reveal a lack of trust among Blacks in research clinical trials, and half doubt that advances in Alzheimer's treatments would be shared. These findings are part of the 2021 Alzheimer's Association Facts and Figures report. Find out more at alz.org/facts.
Limited availability of COVID-19 vaccines means testing will remain important for work, travel, and preventing disease spread. A recent national survey shows widespread confusion about COVID-19 testing. Less than a third of people surveyed know the difference between PCR-based and rapid antigen-based technologies, and more than half say it doesn't matter what kind of test you get. Dr. Manoj Gandhi, Senior Medical Director at Thermo Fisher Scientific, which commissioned the survey, says accuracy doubts could keep people from being tested at all.
Nearly 2/3 of those surveyed believe COVID-19 tests can be wrong as much as half the time. PCR tests are designed to detect SARS-CoV-2 with high sensitivity. Understanding when to use PCR tests is imperative to knowing your COVID-19 status and safely getting back to life's routine activities.
Nearly 3/4 of Americans say they'd choose a COVID-19 test with the most accurate results, even if they have to wait a little longer. Find out more at covidtestinginfographic.com.
And that's Radio Health Journal for this week. Radio Health Journal is a production of MediaTrax Communications. Follow us on Twitter, Facebook, and Instagram to learn more. And check Apple Podcasts, Google Play, and Spotify for a library of past programs. Plus, you'll always find previous segments and information about our guests at radiohealthjournal.org. Join us again next week for another edition of Radio Health Journal.
Coming up next week on Radio Health Journal.
It's a very lonely experience to be in pain because you can't really communicate particularly effectively what it is you're feeling.
How we experience pain.
Then, how our overall health has taken a hit during the pandemic.
They've become more sedentary, they've turned to comfort foods, and so their cardiac risk factors have actually gotten worse.
All that and more on Radio Health Journal.